Hello, we're going to look at a technique for a intrascleral fixation of a three-piece IOL called the Yamane technique. And in this video, you'll see explantation of a dislocated IOL and replacing that with a CT Lucia 602 IOL, which is really great for this sutureless intrascleral technique. So let's get into it. The first step you want to do is you really carefully mark the cornea. You want to bisect that. You want two halves, and then we're going 2 millimeters from the limbus and 2 millimeters apart. That will guide our placement of the needles. I'm also going to use an AC maintainer to keep that chamber formed. This is an anterior segment surgery, so you need something to keep the eye formed if you're not doing this with a pars plana approach. Small pupil here, so we're going to expand it with some iris hooks. You need some visibility. You can do it relatively small pupil, but you're going to have a hard time with some of the passes if you cannot see what it is that you're doing. So we kind of expand that pupil. Wound placement is really critical here. You do not want to be overly close to that right-hand side sclera, because that'll be for your second pass. If you're too close over there, it's going to be very difficult. So you want this incision to be roughly right in the center, but shaded a little bit more to the left, closer to that first pass. The IOL here that is dislocated, we're just simply raising it up into the anterior chamber. We're going to dial that here to make sure that we keep everything above the iris plane. People are often very worried about these IOLs falling. Once you fill the eye with viscoelastic, they tend to stay put. They don't fall very easily, actually, particularly once you get them up into the anterior chamber. We're kind of just cut this in half, in 2 pieces even, and we're just going to remove them. Again, people are very worried about these falling. They do not typically fall unless you push them back there. Some anterior vitrectomy to clean up any vitreous that might be present. Then the AC maintainer. Again, this is really important because if you try to do this procedure with just filling with viscoelastic, you're going to A, fill the eye up with a bunch of viscoelastic, and B, it's going to flatten out. As you approach that sclera, your mark that you made is really important. That first mark is your entry into sclera. Get into sclera quickly, tunnel it. You can dock this CT Lucia 602 lens to that first needle pass. You just want to, right from the injector, as the haptic comes out of the injector tip, just dock that right into that TSK needle. The TSK is a 30 gauge, thin-walled, and so has a larger lumen than a normal 30 gauge. As you're bringing this out, as soon as you see blue, you want to grab, and then you'll make your bulb there quickly. Need a little more help with visualization on this second pass. This is the most difficult pass here. Similar concept. You want to tunnel into sclera, and then as we're seeing that needle come through, we're docking with using some forceps through the main wound. Just dock, pull it through, and as soon as we see blue come through sclera, we're grabbing that, make our bulb, and then you just bury the bulbs and close the incision. And now we've got a nicely centered, fixated IOL. I do PIs here. It'll prevent pupillary block, which is an odd complication. Thank you.